Hi, good morning and good afternoon to everybody. We'll get started in just a few moments as our colleagues join. So good morning, good afternoon, everybody. My name is Nick Diamond. I'm the manager of editorial services at Elizabeth Glaser Pediatric AIDS Foundation, and we're really excited to be starting our next webinar series with the Orphans and Vulnerable Children Task Force, the OVC Task Force. Just to start with some quick housekeeping notes, there's interpretation available in American Sign Language, ASL, French, Portuguese, and Swahili. To use the interpretation feature, you can check the webinar controls at the bottom of your screen and click interpretation. There's a globe icon, and then you can click the language that you want to hear, and you'll be able to select that channel. To hear the interpreted language only, please just click mute original audio. And just as a final note, the webinar is being recorded, and the task force will share the recording at the conclusion of the webinar. Just a few more notes here that you can introduce yourself, please, in the chat, and be sure to select all panelists and attendees. And if you're having any audio trouble, please just make sure that you've selected join audio at the bottom of your screen to make sure that you're hearing our conversation that'll get started. And one final note before I pass it over to our moderator and panelists, we are accepting questions in the Q&A box at the bottom of your screen, and you can submit these throughout the webinar, and we will answer them at the conclusion of the webinar during our Q&A session. So with that, I will hand it over to Martha Mukamanega, my colleague at Elizabeth Glaser Pediatric AIDS Foundation, who will go ahead and sort of frame our conversation and introduce our panelist speakers before the Q&A. So thank you so much, everyone, for joining, and over to you, Martha.
Thank you very much, Nick. So my name is Martha Mukaminega. I'm one of the co-chairs. Welcome again to this webinar. As I'm welcoming you, I'd like to first remind, or for those who might not be aware of who the OVC Task Force is, let me use this opportunity to say that when we talk about OVC Task Force Network, we're talking about individuals and organizations engaged in supporting vulnerable children programs worldwide. One can ask, who is those OVC Task Force co-chairs? You know, they're normally 5 to 7, and they're responsible for sharing information and organizing events throughout the year. And those events are to support technical staff to support better vulnerable children programs all over the world. Another thing I would like to mention related to OVC Task Force is related to a number of events that are organized. And those events include brown bag seminars, webinars, workshops, conferences, and all those have a common aim of building capacity of the OVC community and sharing information and good practices or promising practices. Before leaving this topic, I would also like to mention that the OVC Task Force co-chairs work very closely with a number of should I call them partner? I would like to mention PEPFAR, USAID, CDC, US government agencies, leaders of global OVC and associates, and also ministries of health. And for you, if there is any question you want to ask about the OVC task force, feel free to post it and we'll be very happy to respond to those. During today's webinar, we will have 3 main topics. The first one will be an overview of the mental health and psychosocial support services in the context of OVC programming. That will be covered by my colleague co-chair Diana, and that will be like an introduction to frame our webinar today. The first presentation will be the journey to recovery, psychosocial and mental health support to adolescent girls. That will be, the discussion will be led by Angelina Munangwa. The second presentation will be led by Rudo, and will be the RCT of the REPC intervention on improving mental health and psychosocial support services of pregnant and parenting adolescents. And the third presentation will be led by Carol, and it will focus on supporting children, adolescents, and young people living with HIV. Before going a panel discussion with questions and answers, we will take a few minutes to reflect on the main messages that would have come from the presentations. Before I pass the floor to my colleague, co-chair Diana, I'd like to invite the participants to this webinar to introduce yourself using the chat box, and introduce yourself, share with all of us your name and where you are participating from, and if you don't mind, the organization or the Ministry of Health you are from. Without this, thank you again for attending this webinar. Very much excited to be with you. And I'd like to pass over to Diana. To you, Diana. Thank you.
Thank you, Martha. Next slide, please. So we'll start out this morning with a brief definition of mental health and psychosocial support, MHPSS. And this definition comes to us from Paul Bolton, the MHPSS coordinator for USAID, the first person to hold that position at USAID. So MHPSS, the PSS stands for psychosocial support. It refers to actions we can take to reduce the impact of stressors such as job loss, dislocation, insecure environments that affect mental well-being, or it could be health status, loss of a parent. Mental health support, the MH in MHPSS, refers to the specific conditions, the specific treatments for those who have developed mental health conditions. And that includes depression, anxiety, post-traumatic stress, or PTSD, and substance abuse. Next slide, please. So I don't know about you, but I every week am receiving emails talking about webinars, guidance on MHPSS, which is music to my ears, that there is so much attention to mental health and psychosocial support these days. And USAID is actually developing their first ever mental health policy. And that is under development. They're holding consultations now for that. And Paul Bolton, that is one of his tasks as the coordinator. The PEPFAR 2022 COP and ROP guidance, if you're familiar with that document, I looked back in 2018, mental health was not even mentioned in the COP. This year in 2022, the COP actually has sections on mental health and a section on psychosocial support. So clearly the topics have been elevated at this point. There also have been several webinars, documents from Momentum and WHO on perinatal mental health. It is not uncommon for women in the perinatal period to experience mental health issues. They estimate 1 in 5. There obviously has been a lot of work done on mental health and COVID. WHO has just recently put out the early evidence from the pandemic's impact. And then there even recently has been more and more attention paid to mental health of caregivers. WHO put out guidelines on mental health at work, and there's a duty of care from WISH that had come out, that paying attention to the care of our health workers, our workforce. Next slide, please. So one of the approaches to providing mental health interventions in PSS is a stepped care approach. And this isn't new, a new approach, but it is very applicable to the work that we're doing now and the approach that you're going to see reflected in the 3 presentations that you see today. And it's the idea that the proportion of the population enjoys good mental health or temporary mental health challenges. As you move up the steps, you have people, a smaller number of people that experience mental health conditions with mild symptoms. And then finally, you have a small proportion of the population that has moderate to serious mental health conditions. So to be the most cost effective, we want to design our interventions to match the level of care that a person needs. So if a person is experiencing good mental health, they require less MHPSS interventions than the people that have serious mental health conditions. So we're going to look more closely at these steps, at the evidence that has accumulated on what works at the different steps. Next slide, please. So in steps 1 and 2, the step 1 being good mental health, step 2 being temporary mental health challenges. The idea is that we promote good mental health in all children, adolescents, and families, and prevent short-term problems from developing into more serious or long-term problems. And you can see some of the interventions that there is good evidence to support, like eliminating stigmatization, providing respectful care, providing psychoeducation, coaching stress management, helping the person identify social support. One of the best predictors of how a person copes with a challenging situation is, do they have good social support? Also, for people at these steps, we would want to promote functioning and life skills. And then here we want to be able to identify the mental health conditions and risk factors that exist for these people. So even though someone is experiencing good mental health or temporary challenges, is that person at risk for developing more serious problems? So this is the steps at where ideally we would be including screening for all people. Next slide, please. At step 3, where a person is experiencing mild symptoms, mild mental health conditions, we would be providing brief psychological interventions. We would start with what was provided in steps 1 and 2, which should be provided to everybody, good PSS support. Then we could add brief psychological interventions for mild symptoms. Now, it used to be thought that we needed specialists to provide these kinds of interventions. And we know now from the evidence that that is not true. Mental health specialists are not required to treat people with mild mental health conditions as long as they are trained well and that they have supervision. Next slide, please. The 4th step, people that have mental health conditions with moderate to severe symptoms. These would include conditions like bipolar disorders, severe depression, schizophrenia, psychosis. These are people that are going to require more intensive interventions that are provided by a specialist. And medications may be necessary. So as you'll see in today's presentations, this step is sometimes not addressed at the community level, but is more at the specialist or clinical setting. So that is a brief introduction of the approach that we're taking with MHPSS. And we will return to this idea of a stepped care approach in our last presentation. And so I'm going to turn it over now to Lauren to get to the presentations. Thank you.
Thank you, Diana. I am pleased to now introduce our first presenter, Angeline Munangwa. Angeline is a development practitioner with more than 10 years experience working with vulnerable populations in Zimbabwe. She holds a Master of Science in Community Psychology as well as an LLB. In Musasa, her time is devoted to supporting survivors of GBV and also includes implementation and monitoring of projects in the Matele land region of Zimbabwe. Over to you, Angeline.
Thank you, Lorraine. Good afternoon, good morning. So my title is Journey to Recovery, Psychosocial and Mental Health Support to Adolescent Girls. Next slide, please. So Musasa is an organization that was formed in 1988 to respond to incidences of gender-based violence perpetrated against women and girls in Zimbabwe, making use of multidimensional and interventions that speak to response, with pillars that speak to response, prevention, advocacy, communication, and meal. MHPSS has also been actively involved in the passing on of the Domestic Violence Act in 2007, and it continues to impact on policy direction in the area of gender and GBV. Next slide, please. So in terms of the work that has been done or that is being done by MHPSS over the years since 1988, MHPSS responds to incidences of violence in Zimbabwe, and evidence has it that 1 in 3 women aged between 15 to 49 have experienced GBV, and 1 in 4 have experienced sexual violence. And in 2020, through our national GBV hotline, there has been observed an increase in the incidences of GBV by about 175%. Hence, MHPSS has adopted the client-centered and strengths-based approach in response to the incidences of GBV, and provides mental health and psychosocial support to GBV survivors on the principle that the clients are their own masters of their situation, and what needs to be done is just to make sure they are empowered to make informed decisions about their situations. So the MHPSS acts as a sounding board and information provider to provide the clients and the survivor with a number of options to take should they experience GBV or for the situation that they are in. So MHPSS also uses eclectic approach, which integrates different techniques to address the specific needs of the survivor. Next slide, please. So for the psychosocial support and the mental health interventions, MHPSS uses the community-based approach as well as the response approach through specialized counseling. So from our community-based approach is mainly about demand creation, where the client is at the center of our services, and we are using the client-centered approach in order to respond to the current and the ongoing needs of the client. And we also notice that GBV takes place in the community. And when we provide the services through our centers and so on, the clients are going back to the community. Hence, the community becomes the center of our intervention. So in the community, we do have community platforms where we have created community-based clubs who assists through identification of cases. When they identify the cases, they also provide first-line support through their lives methodology. So the community-based structures, these include the child care workers, the village health workers, and a specialized group of the community-based structures called the Pillars of Hope. We have evidence as it through MHPSS that we've observed over time that it's not easy for the adolescent girls to verbalize abuse and to seek help in time, and to also seek protection services well in time. So we've created the Pillars of Hope, which is a group of adolescent girls and boys who then help. They've been trained, capacitated with the skills to identify cases, with the skills to be able to provide psychological first aid to their peers. They identify cases as they play in the community, as they walk to school, as they do activities in the community with their peers. It's easy, they use the language they understand to be able to pick up the cases, to be able to identify cases. So all these are happening in the community. And when this happens, the survivors, the adolescent girls and young women, they have got multiple platforms to access the services through our walk-in counseling centers, through the one-stop center mobile clinics, through our toll-free hotlines. And we also have this intervention where we provide safe spaces for for the adolescent girls and young women to engage on their own, to engage about how they define abuse, the definition of abuse from their own perspective, and to engage on the possible protection services available in the community and available around them so that they can access the services timely. So the pillars of hope also are, it's a community-based intervention. And with this community-based intervention, they've been capacitated to provide first-line support using the LIFES methodology. Next slide. So moving from the community, when the cases have been identified, they then referred for specialized counseling and support services at Musasa. These are provided by our on-site counselors, family therapists, social workers, CBT therapists, and psychologists who are trained. So when they get to Musasa, there is a screening tool that is administered and an assessment is done. The screening tool is about 13 questions. It's used to determine the form of abuse that the client would have experienced, and also to determine the form of support service they should be able to access. And after, when that assessment has been done, and if a client says one or a yes to one of the questions in the screening tool, they are then appropriate service package is then developed. Through the appropriate service, counseling is provided in the process. And counseling in thus the once-off counseling is not enough, is what we believe. So what happens is that after the counseling, we believe the client is going back to the community. When they go back to the community, we want to find out what is happening. Are they able to integrate? Are they recovering from the trauma? So the counselor develops a care plan together with the client, and that care plan is then followed along the line, which also includes the follow-up plan, where the client is either called or a home visit is done just to determine if the client is recovering well from the trauma. So the eclectic models are then used to support the client, and also the CBT. Survivor clubs are also when the client go back to the community. The survivor clubs that I mentioned earlier on, they continue to support the clients and continue to engage with us, giving us feedback on how the client is recovering. Thank you. Next slide. So in terms of results, we have documented increased mental resilience among survivors, with about 103 girls who've been trained in the past 6 months on resilience building. We've also noticed the clients who are recovering from trauma being able to start their own small businesses, being able to be economically independent, such that that would then it's a sustainable way of ensuring our clients holistically recover from the trauma. There's also regained strength among survivors to take charge of their lives and body and realize their own inherent strength and resources. Then the clubs I mentioned earlier on and the pillars of hope, they continue to sustainably provide GBV awareness platforms within their communities, and they act as surveillance to their peers in terms of ensuring timely reporting of cases of violence. Next slide. So for the 3 key lessons that we've learned over time, we've noticed that the client-centered approach, it instills hope in the survivor to trust their own inherent power, which is very key in terms of recovering from trauma. And to be able to chart their own path along the way, they have to be an active member in terms of developing a plan of recovery and to thrive after the trauma. So the client-centered approach is very, very critical, and it is very key. The first line psychosocial support services that is provided by our our community-based structures, we've seen that they are very critical, and the mobile clinics and the toll-free hotline, they facilitate a wide range of services that are available for the clients to access the services. If the client is not able to walk into our centers, MHPSS takes the services to the communities through our mobile one-stop centers, or they can call the toll-free hotlines. And these packages enabled all the survivors, no matter how remote they are, to be able to access the services. Then the peer-to-peer support groups, these are key, the pillars of hope in ensuring that there's first-line support that is provided to the survivor when they report abuse, and there's continued support to the survivor, even post accessing the services at MHPSS. Next slide. Thank you. And over.
Thank you so much, Angeline. I am happy to now introduce our next presenter. Rudo Olga Shumba is an SRHR Programs Officer at REPSI Zimbabwe. She holds a psychology degree and a postgraduate honors in social policy and management from the University of Cape Town, and a master's in child rights and childhood study. Rudo supports REPSI's child protection work with a focus on sexual reproductive health and rights, and mainstreaming mental health and psychosocial support for young people. Over to you, Rudo.
All right, thank you so much. Good morning and good afternoon, everybody. I will be presenting on the REPSI intervention on improving MHPSS for pregnant and parenting adolescents. Next, please. So as REPSI, we've been working with adolescent and young mothers on the intervention focused on supporting adolescent mothers, as well as their partners who are the fathers, in groups to overcome challenges associated with unplanned parenthood. So in our line of work, we work with key stakeholders. We've worked with the clinics, we've worked with the village health workers, the child care workers, as well as the Ministry of Education. So with the Ministry of Education, we're working with them because we're also trying to reintegrate the adolescent mother back into school. With the village health workers, we're trying to ensure that these young people have that clinic and community collaboration, whereby they know how to access the clinic facilities, as well as the childcare workers in terms of child protection issues. So we mainly mainstream psychosocial support as a preventative measure of mental health conditions. And we use a resilience-based approach to say that even though the adolescent mother has gone against the social norm, and she's become a deviant, she's still able to get support so that she has the ability to bounce back and reintegrate back into the community. Next, please. So in our interventions with the adolescent mothers, we've been using an ecological systems theory. So we look at the different layers, the microsystem, the mesosystem, and the exosystem, to find out what are the psychosocial distresses within the adolescent mother's life. So the key ones we came across were the poor educational outcomes, socioeconomic difficulties, the ongoing COVID-19, which really had a negative impact on their mental health, and then rejection from community, inadequate access to quality maternal and child health care, as well as SRHR services, as well as unpreparedness for parenting and lack of support. So we find within these systems, we came up with psychosocial interventions, which would then work with these adolescent mothers to alleviate all these challenges that they're facing. Next slide, please. So in our intervention, we trained peer educators who were the mother-to-mother, where they would support peer support. So there was peer support, and they would conduct group sessions on different topics that we found within the different systems to be challenging adolescent mothers. And the key ones were GBV, SRHR, HIV, marriage, positive parenting, as well as positive. sorry, sorry for that. So we had the M2Ms, we had the F2Fs, and these leaders were responsible for support, for providing psychosocial support for the other mothers who were within the communities that were not trained. We used a PSS assessment tool, which these facilitators would then conduct. If we find that the adolescent mother or the adolescent father needed secondary support, the child would then be referred to the social worker who would be within the district. And then we also trained healthcare workers on mainstreaming psychosocial support, as well as mental health and childcare services. And with these healthcare workers would work on their attitudes as well, as well as their perceptions around adolescent mothers. As we're saying that within the community, they're discriminated against and they're not accepted. So we're trying to reintegrate them and ensure that they seek these SRHR services. And then we also provide expecting adolescent and young mothers. So we have the emergency fund, which would then alleviate some of the challenges because they're not
We seem to have lost our presenter. I think there might be a technical difficulty here with the internet connection. Lauren, I think it might be best to move to our next presenter and come back to Rudo.
Okay. Okay, we will do so. So thank you, Nick. I'm pleased to introduce our next presenter. Carol Wogren is a clinical psychologist with a nursing background and is the mental health specialist with Jindiri, Zimbabwe, where she focuses on better integrating mental health services into the care of children, adolescents, and young people living with HIV. She brings 40 years of experience working with children, adolescents, and families coping with illness, trauma, bereavement, and other life challenges, as well as system strengthening and capacity building with professional and lay care providers from community to national levels. I'm happy to hand it over to you, Carol.
Good morning, excuse me, good morning and afternoon, and I suppose evening, depending where in the world you are. I'm happy to join you today. And so if we can have the next slide, please. So I work with Jindiri, and as you heard, it is children, adolescent, young people living with HIV. And it goes back, we started 18 years ago in 2004 when 6 adolescents came to really ask for more than just the medicines. They were asking then for mental health and psychosocial support to help them really survive and thrive now that they did have their ARV treatment more available. In 2009 then grew and introduced our community adolescent treatment supporters model, our CATS, who were working in facilities, homes, support group, and mobile health, really with the goal, again, to help them really survive and thrive and to improve through improving HIV and mental health outcomes. Next slide, please. And so an overview of what we do is it is primarily peer-led services and community clinic and digital-based, providing support through these variety of platforms and including support to families and to working with the healthcare workers as well. And we do this through, we have 2,400 community adolescent treatment supporters, the CATs, and young mentor mothers. And the young mentor mothers is a cohort, they are CATs who then have gone on to become mothers, and they work with, adolescent girls and young women who are pregnant and breastfeeding to provide them the psychosocial support as well as that we encourage them with their HIV treatments. And in Zimbabwe, we're now supporting 64,000 children, adolescents, and young people across the country with the goal of improving care, certainly across the 95 spectrum and our cascade, and as well as improving outcomes in their mental health, their sexual reproductive health, protection, and secondary prevention. Next slide, please. And so this depicts what you were hearing. Actually, this links with the stepped care pathway is our approach to integrating mental health and psychosocial support for children, adolescents, young people living with HIV. And similar to what you saw in the general model, we find that the bulk is at the bottom, the widest part of the pyramid. And let me say that from research done in the region, we see evidence of mental health risk as high as 60 and 65%. But what we find in our program, from our programmatic and research data, is what we see is there is actually the bottom section, which is our largest part of our cohort, are managing their stress, the life stressors that they come up against, which actually are plenty, that they're managing well and overall are doing well. And they do this with the support of the CATs, who provide information on mental health literacy, support, counseling, and referrals. Though this group is actually, they're pretty much, they attend support groups, or the CATs facilitate support groups. They provide PSS in homes, clinics, and through mHealth. And this includes not only counseling to the young people, but counseling to the caregivers as well. Then moving up the ladder, what we see is there's certainly a much significantly smaller group, but it does show evidence of mental distress. The CATs conduct biannual mental health screening and to identify any problems that are going on. They manage this through a multidisciplinary team, and again, through both home visit support groups and mHealth. And they provide counseling that draws on cognitive behavioral therapy, positive psychology, because we think it's really important to emphasize and focus on strengths, and narrative therapy, recognizing the importance of people being able to tell their story, to understand their own stories, and to have it witnessed and supported by caring individuals. And so the CATs both are, we find, very effective in helping people just manage in general, and as well as addressing problems when they are, before they really escalate to becoming mental disorders or illnesses. And again, then a much yet smaller part of the population, you see the 11% here, is found to be at risk of common mental disorders, particularly anxiety, depression, which may include suicidal ideation, and as well as possibility suggestion of psychosis and through having hallucinations. And importantly, we also ask about substance use, since substance abuse is an increasingly significant problem and that affecting young people today. And so when they identify through their mental health screenings and their other work, when they identify problems that are, really putting a person at risk, showing some symptoms of depression, anxiety, or expressing suicidal thoughts, using substances, they refer them not only to the community cutters in the clinics, but potentially to the mental health nurse in the districts that they're working in when they're at all available. They increase their counseling and the monitoring and support that they provide and that is provided by the Gendarmerie district teams. And they engage in multidisciplinary case management and case conferencing. And this piece is really critical, that we have to work as a multidisciplinary teams where we can address the various contributors to the problems that they're having. And certainly here, cutters that address child protection and social protection are extremely important. We certainly, you heard from Sasa at the beginning, identified GBV and other issues of violence. And so it's important that we have our referral sources, that we build our networks, and that we utilize them so we really can take a multidisciplinary approach to the problems that are identified. And then lastly, though effort is made to prevent these and to promote well-being, there is a small percent of young people who do progress, their problems progress to the point of developing common mental disorders or mental illnesses. And for these, again, we increase the intensity of the care and support that is offered. We know, though, that certainly issues of things like hospitalizations and whatnot are problematic in resource limited settings, as much of our area is. And but what we found is that we really can be quite effective in managing even the more serious cases at home, providing we increase the level of support to the child, to the family, the ARV monitor, adherence monitoring, and when needed, support for psychiatric medicines. But again, I want to emphasize, because sometimes I think it is approached as if not having medicines, everything else is second best. But we really, through identifying, promoting well-being, through preventing mental health conditions and identifying those and increasing the care we give, we really are able to manage most of these cases quite effectively as home-based. And so we do this through, as you see on the right side of the pyramid, the capacity building of service providers, families, and communities. And very, very importantly is providing support and supervision for the CATs and young mentor mothers, because they are first and foremost beneficiaries who are living with the same stressors as those who they're providing support for. So we have to give them the ongoing care and support as well. Next slide, please. So we monitor this through our routine programming, our data, and that is the CATS screen clients monthly or biannually, twice a year when they're on standard care, and increase that to quarterly when they're on enhanced care. People are on enhanced care if they have increased vulnerability, whether this is due to having screened that they're at risk for a mental health condition, whether they're pregnant or a breastfeeding young woman, or if they have, for example, high viral loads. So anything that suggests they are at increased vulnerability, they're screened more often. We screen using the Shona Symptom Questionnaire, and which is a validated tool for adolescents and adults actually too in Zimbabwe. And we have added a 14 question item questionnaire, and we've added a last 15th question on substance use. And anyone who's identified as being at risk is screened again at 3 months to make sure that we see improvement, or that we do case conferencing to figure out what else is needed. And you just see the cascade here. So every month it's reported how many are screened. Here we see 500 were screened in these districts in this month. 16% were identified with at risk for common mental conditions. 98% of those received increased increased support, and 87% of them were referred on to primary counselors, to mental health nurses, or to other cohorts for the support that they needed. And then importantly, we track and we see that at the end of the month, 89% of these the referrals have been completed. Next slide, please. And we also conduct ongoing, we've had quite a range of research, both qualitative and quantitative, and using various methodologies to really capture the lived experience and the service delivery needs to make sure that our interventions are working. We've also had 3 randomized controlled trials that have demonstrated that improved psychosocial well-being and mental health, and along with viral load. And a recent one of our control trials was in collaboration with Friendship Bench, where the enhanced counseling were given by cats who received additional training in problem-solving therapy, and we see that when they were working both arms, both the standard CATS counseling and the enhanced counseling, showed a dramatic reduction in the risk of mental health problems. All of these articles, all of our research is on our website, or you certainly can reach out to us if you want more information. And can we have the last slide, please? So the lessons learned is mental health and psychosocial support is a really essential component of care in order to ensure optimal outcomes. We know that task shifting to peer counselors is wanted, supported by a large global consultation we did on behalf of WHO, and where the young people themselves emphasized the importance of getting support for mental health and their psychosocial needs, and that this is critical to their well-being. We know it's effective and scalable, providing put in the sustained investment in training them and mentoring them and ongoing support. These are not one-off quick trainings. And then finally, how important it is to have a robust multidisciplinary system of response, and that this is essential to the care that we provide. So thank you very much. And again, happy to join you all.
Thank you so much, Carol. My name is Julie DeSoto, and I'm a co-chair on the task force. Just reflecting on the really interesting information that we've heard, the helpful information about how to integrate these models or similar into our program. And just to echo the importance of using that stepped approach. I think we've seen some of those critical steps being addressed across these presentations, where we're trying to target those kind of in the middle who are not without mental health challenges, but also those who are not critically ill, to really make the most impact where we can. So we are going to, as I speak, we can move to the next slide, please. We're inviting participants to share in the chat box what you have seen or heard today that you might be able to address or use in your own programming or for future programming. So as a quick reminder, we heard from Musasa about their safe shelters, the GBV screening tool that they have been using, and the client-centered approach, as well as increasing mental resilience among GBV survivors. We heard from Repsi also about group safe spaces. So this is kind of a theme that we've heard. And then adolescent mothers being a very specific target group, provision of care and services to them has shown to be really important. And then from Zandiri, we saw that they were being very intentional about, where on the pyramid they're addressing mental health challenges or problems, and how they've really prioritized using screening and mental health literacy. So those are some of the themes that, as I listened, they really stood out to me. And we just want to invite a little bit of participation now from everyone. So if you can type in the chat what you're thinking in terms of what you've heard today that you may be excited to incorporate in your own programming or maybe in future programming. So we'll just give everyone a moment to share their thoughts in the chat. And when we send the webinar report around to all of you afterwards, we will be sure to include all of this information and learnings that you're sharing here. So we'll invite you to type your responses in the chat, and I'll go on to mute for just a couple of minutes here as we allow you to respond. Thank you. And Rudo, I believe Rudo has logged back in. That was our presenter who had some internet challenges. So Rudo, I think we have your last 2 slides. If you'd like to run through those as people are sharing in the chat, their typed responses, and we'll let you run through those 2 quickly, and then we'll move to the Q&A section, which we're really excited about. Janet, our co-chair, will be facilitating that, and this will be a really great place for you to share your thoughts and questions with the presenters. So over to you, Rudo.
All right, thank you. I'm sure you can hear me clearly now. So as I was going on, so when we did this intervention, we first conducted a baseline to measure the current psychosocial distress amongst adolescents and young mothers, as well as their mental health. In this, we used the PSS assessment tool that I mentioned recently. So this is the results that we got from the baseline interventions. For this endline intervention, we conducted it with adolescent mothers from Chipinge, Rushinga, and Epworth. So you'd find that there were significant changes amongst the adolescent mothers. So you'd find that maybe during the baseline, 68% would say, I'm happy in my role as a parent. And then during the end line, the result increased to 90% to show that they were better equipped for their parenting role, which reduced parental stress amongst adolescent mothers. Then there was also, on the whole, I'm satisfied with myself, which increased from 22% to 45%. It's not significant because as we were working, we realized that there were more interventions, that we needed more time with these interventions with the adolescent mothers. Like, for example, with the school reintegration component, as much as we would raise awareness, we still needed to conduct more community dialogues amongst community leaders as well as the school, because young people were still reporting that as much as they were trying to go back to school, there was still the issue of discrimination from their peers. And then there was little interest or pleasure in doing things. This reduced to 32%, showing that as she went through the support groups and she also received psychological first aid from her peers who were trained by REPSI, they were able to then increase their self-esteem as well as be positive about life, which illustrated the issue of being the ability to bounce back, which was our resilience-based approach. And then we also looked at getting an education is important to me. As I emphasized, you can see that there was an increase on that. And then there was also people like to spend time with me. That increased to 57%, also illustrating that she became a better person who other young people wanted to be around. So as you can just see, respondents showed statistically positive changes from the baseline to end line. So on summary, there was decreased depression up to 75%. There was improved gender attitudes as well, because we had the component of the fathers. As you see in programming, when we're trying to deal with adolescent mothers, we always leave the boy child, of which the boy child is the one who lives with the adolescent mother. So there was need to train him on positive masculinity, resulting in the 71% increase. And then there was decreased parental stress by 69% and improved resilience by 67%. Next, please. So our key lessons learned, as most of the presenters were showing, that group spaces do have an empowering effect on adolescents, because the component of psychological first aid from peers is something that young people really do appreciate, because they're able to speak in the same terminology and they understand one another. They have common ground. They don't
fun drive last night, so no man no put any negative comment.
So we did feel that young people would not feel discriminated or be afraid of an adult. And then community conversations are the key driver in deconstructing the stigma around adolescent mothers. So you'd find through community dialogues, community leaders were able to see that, no, these types of approaches, they're not trying to promote teenage pregnancies, but we're trying to say the young person has become a mother. Are we going to leave her, or are we going to support her? So you find most community leaders would then come on board and then support reducing the psychological distress of adolescent mothers. And then involving the families of adolescent mothers create a supportive environment. As we know, when a teenager becomes pregnant, there's a lot of conflict. So we were able to then rope in the parents and caregivers. And this increased the support, as we also managed through counseling, we managed the issue of conflict resolution. And then there was also provision of psychosocial support at Waiting Mothers Shelter was preventative of mental health challenges. So as I said previously, we mainly focused on the prevention aspect. So going through, so our social workers would go to Waiting Mothers Shelter, where they would target these adolescent mothers and provide them psychosocial support, whereby they are able to prepare for motherhood. Because already in the household, there's that conflict of, you're now a child who has a child, so who's going to support her? So we would then go to the Waiting Mothers Shelter and constantly provide psychosocial support as well as counseling. The involvement of adolescent fathers resulted in shifts in the thinking about GBV. So this was a key component that we saw that reduced psychological distress amongst adolescent mothers, because most of them would want to get married to their partner. And you cannot, as we know in counseling, you cannot force someone to make a decision. So we roped in the adolescent father so that he knows that the parenting role is not only for the adolescent mother, but he also has a role to play, as well as through our positive masculinity tools, he was able to then share the gender roles, to share the roles within the household that would then reduce the psychological distress of adolescent mothers. Next, please. All right, thank you so much.
Thanks so much, Rudo, and thanks to everyone. A lot of common themes, a lot of interest, a lot of Q&A coming through from our participants, and really appreciate the conversation and the thoughtfulness around this. A couple of things right before we go into our Q&A around common themes and cross-cutting themes. So I think, as we've seen, mental health is really a continuum. It's a continuum of care, and that as community-based providers, we want to caution around medicalizing mental health and PSS, because PSS delivered by trained peers with adequate support supervision is really a cost-effective way to be able to prevent the evolution of more severe psychiatric conditions. So in the spirit of this, why don't we get going into our Q&A? And let me go back to you, Rudo, with a question that comes from one of our participants, and that is really around resilience. If you could talk a little bit about your resilience training and the tool that you use, both to measure resilience and to understand changes in resilience, that would be great. Over to you, Rudo.
All right, thank you. So to measure our resilience, we would use so we have a REPSI tool, which is called the Psychosocial assessment tool, which integrates from different tools. We would have the mental health tool, as well as the child youth resilience-based tool. So those are the ones that we would use in the end line as well as the baseline.
Thanks, Rudo. And just a quick follow-up. How do you contextualize those tools? We've talked a lot about tools. There are standardized tools, and standardized tools are always the ideal, but we know that they're not always available and they may not always be contextually relevant to different contexts. So can you talk a little bit about how you chose the tool and the questions on the tool and how you contextualize that?
Okay, thank you. So during the trainings with the adolescent mother leaders and as well as the fathers, would then validate this tool. So we had the tool already, but then would sit down with the young people and ask them if these questions are relevant. So you'd find, even if you see our tool, there's some sections of the original tool that would remove, because then they would say, this is not relevant. Like, for example, there was a question on whether they have water every day. Those were some of the tools that we would find, and then would remove those sections because the young people would then illustrate that it's not important. So that's just to answer, that's how we contextualize it.
Excellent, thank you. And speaking of contextualization, we also know that one of the challenges here, both around demand and service provision, is really the stigma. Or maybe one might say, how does one contextualize the concept of mental health and PSS in the community, both to engender community demand and also to sort of neutralize or shift or transform how people understand or respond to the idea of mental health and PSS. Angeline, can you talk a little bit about how Musasa has been able to contextualize mental health and PSS services in the community, and how you've been able to help open up areas for more demand, and to help people understand and be more open to these kinds of services?
Okay, thank you. So Musasa, through experience, we've observed that it is not only enough to provide specialized services to the clients. So we've come up with a comprehensive package of demand service interventions, such as the community dialogues, the community visioning sessions with the communities, the road shows in order to create demand, the radio programs, so that those that are not aware of the services can also get to hear about the services and where to access the services through the radios. We also have community conversations, because we also notice that the communities, they are the gate, the community leaders are the gate keepers of some of the cultural values that are harmful. So we've also engaged with the community leaders, who then produce commitment charters. The SUN commitment charters is how they are going to be doing prevention programs within their communities, and how they're going to be sharing access to services with their community members. So it's some of the those are some of the packages that we have as an organization.
And Angeline, just a follow up to that, what has been most surprising or most encouraging to you? What has been most surprising, you know, as you've supported teams and engaged with community leaders on really trying to destigmatize PSS and mental health?
The most surprising thing is that it looks like the communities in general and the community leaders specifically, they simply lack knowledge, and with trainings, with more education, with more awareness, they are able to change in terms of their attitudes and behaviors, and they are able also to enable their communities to open up in terms of talking about abuse, dialoguing about abuse, and also to be able to be welcoming programs in their communities. They open up to programs. They also open up channels of communication, as well as some service providers to be able to be coming to their communities to provide the services.
Thanks, Angeline. That it's very encouraging, right? Because as we know, both from the client side and from the community side, really, expanding and acceptance of PSS and mental health services can be a big challenge. I wanted to shift maybe the conversation over to you, Carol, and noted that as you were speaking, you really emphasized the importance of support supervision and the importance of investing, that peer counselors certainly is a through line throughout all of this, that adolescents, young people want support from their peers. They do not want a medicalized mental health PSS program, but that to do that well, one really needs support supervision. So can you talk a little bit about training and support supervision? Thanks.
Yeah, thank you, Janet, because this is critical, particularly when we're using peer counselors. The training we have, anyone for cats in general, they have a week-long training in order to become cats. Mental health, psychosocial support is part of that training. And then once they've completed the training, they're placed in facilities. In the facilities, which is where they get their caseloads, and from there they do home visits, other work in the community, and conduct support groups. But so they have a supervisor in the facility who is either a primary counselor or the sister in charge, a nurse, and we also provide, through Jandiri, we provide training, sometimes virtual, or when they come together for their CATS coordination meetings every other month. We provide training specifically on mental health, on understanding the conditions, working with them carefully on learning to do the screenings, and not only just run through the yes/no questions, but we teach them to use the screening as a counseling tool. So if someone says, yes, they are having nightmares, they know to ask, so what are the nightmares about, or what's going on, or why do you think that is? And then they get also support supervision in every district. We have a Jandiri district team, which is a mentor, maybe an associate. And they work with the cats on a weekly basis to identify any support they need in their cases that the clients are managing, as well as working with the cats to understand their own stressors and supports that they need. So these are ongoing trainings. There's also visits to all the facilities. Contact through WhatsApp is a main one, to really identify and to help them continuously build skills. We also know that from a very important piece is capacity building with the healthcare workers, who tell us they don't feel comfortable working with the mental health, and particularly they don't feel comfortable working with children and adolescents around mental health issues. So we work closely with government. These are government facilities that the cats and the young mentor mothers are in. And we work to also provide in-service trainings, as well as ongoing mentoring through visits to the health facilities to build the skills of the teams. And then finally, we conduct multidisciplinary case conferences with complex cases, so that we kind of have a lot of different disciplines in there to address the problems using the resources that are available in the community. So it's the initial training, it's ongoing mental health, sometimes virtual trainings, which we got much better at in COVID, forced to do that when we had always meant to. And then ongoing support with the cats from the district teams who work with the smaller groups of cats spread across the country.
Thanks so much, Carol. Very, very helpful, and I'm sure resonant across the different presenters. I think one piece I also wanted to note is your work with government. And I think as a global community, move forward in this really important conversation and seek to expand what works, particularly from a community cost-effective perspective. Working with government is essential. Government will be leading the way, building our approaches side by side, government. And I wondered, either Angeline or Rudo, if you had any other input or reflections on approaches to working with government and how you've done so at any level, at community, at district, at national level. Rudo, over to you.
Thank you, Janet. So what we have seen at REPSI is that for us to be able to work with the government, we need to train them on mainstreaming psychosocial support. So the moment we train them from national level, they're more accepting of our interventions. And then they assist us with training their personnel at district level as well as community level. Like, for example, with our Ministry of Social Welfare, we have a good relationship where we train the national stakeholders, and then we trickle down up to what level, where we train the childcare workers who are responsible for household levels. Thank you.
Thanks so much. I'm just looking at our chat and looking at our Q&A simultaneously. I've seen a number of questions from presenters around GBV, both in terms of a screening tool and follow-up and support for adolescents. And maybe I'll turn back to you, Angeline, if you could talk a little bit about the tool that you use for GBV screening and how that the team then is following folks who are recovering from GBV and what that support package and follow-up looks like.
Thank you so much, Janet. So I'll begin with the screening tool for GBV services. Like it says, it's the screening tool for GBV services. It's used to determine what form of service the client would need following the administration of the tool. And the questions in that screening tool are such that they would determine the kind of service where the client should be referred to and whether the client is in immediate need of a service. For example, they need to be referred to a health facility for the survivors who have experienced rape. So it also guides us in terms of the agency of the abuse, also in terms of comprehensiveness of the services that the client would require. So they are the different questions, and those questions, they are then evaluated by the counselor as to determine the way forward about the client.
Thanks so much, Angeline. Oh, go ahead.
And with regards to follow up of the clients, we noticed that when clients are released from our counseling centers or from our shelters, when they go back to the communities, it's either they face rejection from the communities, there's blame why they would have reported the cases. There's also maybe they are disowned by their own family members. So they face a lot of challenges when they go back to the community. Hence, it is critical for us to make follow-ups. We make a follow-up as soon as the client leaves our center, about an hour or two, depending on where they are going. We make a phone call to determine whether they've traveled well and whether they've settled well, that they've been accepted back in this. We then facilitate that the client comes back to our facility. We do have shelters. The shelters are designed in such a way that we shelter the GBV survivors as long as the challenges with integration or reintegration back into the family or into the community. So follow-up is very, very critical in terms of psychosocial support.
Thanks, Angeline. And your comments just remind us again, excuse me, the important role of community. And when we're looking at a socio-ecological approach to mental health, it's so much more than just the person who's experienced trauma or experiencing any kind of distress, but the ring of support around her or around him. And again, to emphasize the important way, really, advocacy and elevating what we can do as lay workers, as community-based providers, with adequate investment, adequate support, and continuous engagement of our community, government counterparts, to be able to really create that circle of support around children, adolescents, and young people. Let me also ask, we've noticed in the chat a few questions around published studies with any of these tools. I know, Carol, you mentioned published studies with Jindiri. Maybe over to Rudo and Angeline, if you have published studies from the RCT, obviously from REPSI is a published study. We are happy to share links to any of those published studies. We'll send the info, as Diana shows, through the OVC Task Force listserv. Moving on, I think we have about one more question left, and then we can wrap up the session. And I wonder if, oh, from Godfrey, thanks for your comment. Again, any other reflections? Back to you, Rudo, as you've been listening to your co-presenters and to the questions coming through the chat, any sort of last key reflections that you would want to offer, where we go from here?
Thank you so much. I think just my last words is that in our implementation with working with young people, we need to always know that they're not a standalone. As I was saying in my presentation, we need to really emphasize on the ecological framework of involving the parents, the caregivers, as well as the community, as well as the service providers, to ensure that, because if we work on the individual alone, who can be the young person, we're not going to see any change as long as we're not working with the external environment. So the young person can be changed and become resilient, but as long as the community that the child is within is not safe and supportive, our work will be undermined. So thank you very much for this opportunity.
Thank you, Rudo. And as you're speaking, back to you, Angeline, around advocacy. I think as we look at our community of practice and actually the evidence, and quite strong evidence, about the impact of peer-led support around PSS as a prevention strategy to more severe psychiatric conditions. Angeline, from your perspective, what kind of advocacy do we need to engage and embark in as a community of practice to really elevate and work with our counterparts, our donors, our government counterparts, to elevate the importance of this and the importance of investment in this cadre and in these structures?
Thank you, Janet. In my opinion, I think we would need to capacitate. We do the bottom-up advocacy. We engage with the communities, we capacitate them to be able to do advocacy at their own, to be able to take up the issues from the community level through to national level. So it's very, very important to have the communities involved in our advocacy, to have prevention and response to GBV, and in terms of psychosocial support and mental health. So once they understand the work we are doing, they are able to identify where the service provision is also lacking, what should be done, and they are also able to engage on their own. I think it is also critical that they are able to mobilize their own resources towards doing advocacy work. And so as Musasa, we have got this initiative through what we call community visioning, where we are capacitating the communities to actually take up the prevention and response to GBV on their own. They mobilize themselves as a community, and they identify the issues around HIV and GBV that are affecting them, and they engage the community, they engage the local service providers, they engage at district level, they engage through, and we also assist them as Msasa, where we are sitting, we assist them to be able to access the various platforms where these advocacy issues can then be submitted and listed. Thank you.
Thank you, Angeline. As Carol asked you the same question, and as we're coming up to the close of the webinar, if any participants, we would love to hear your thoughts about other webinar topics you'd like to see, so feel free to drop those in the chat. I go back to you, Carol, with the same question around advocacy. What do we need to do, and how do we elevate these practices and calls for greater investment?
I think that it's a multi-level approach, and to really engage the different cadres. I mean, certainly where we are, the faith-based cadres are really important in people's lives. And so to be engaging with them to talk about issues about, as well as caregivers, again, the different cadres through government, to really talk about mental health, to get it really out there, and psychosocial support. And the piece that I guess to me, a main thing is just that human connection goes a very long way, even when we're talking about more serious mental illness. So when we can start really talking about problems, when we can address them, people are going to develop their capacity to identify issues, but again, to really get people talking. And I think that there's a lot of stigma and secrecy around this mental distress. And so I think the efforts that we use, again, to engage all the different community-based, government-based cadres who are working with young people, but again, just really promoting the care and support, addressing issues around stigma and discrimination are huge, trying to get even the WHO messaging around HIV, you know, the U equals U, the, you know, undetectable means untransmittable, so that to really start working on kind of decreasing the stigma and the discrimination, but as well, not only around HIV, but around mental health issues as well.
In general. So. Thank you. And thanks to all our presenters. The other piece I'm reflecting on is the importance really of evidence, isn't it? And so as we think about how we contextualize screening tools, how we contextualize programming and interventions, how we contextualize those tools and our approaches so that we can continue to build the evidence will lead the way with our donors and our government counterparts. And building on this webinar, we hope to continue the discussion and continue to share as a community of practice, right? Tools, contextualization, evidence, so that we can move together and really elevate and invest in what we need to do as a community-based cadre because of the incredible potential this has to really address and prevent more severe psychiatric conditions and really help us all retain the connections we all need to thrive and survive in our immediate context. So with that, I think we're at the hour. We will be sharing all of the answers to your questions in the chat. We thank you so much for your participation. We will also share follow-up and the slide and presentation and recording with everyone here. We look forward. Please join us and sign up to be on our listserv for the OVC task force. And we always welcome any recommendations of additional webinars that you'd like to see. So thank you all again. Good day, good evening, and look forward to the next time we meet.